Hello, everyone. This is welcome. This is our first ever live case interpretation with Dr. Sarah Wilson. We are thrilled to have you join us for our very first session. We wanted to try a new, more interactive format for learning, one that puts your clinical questions and interests at the center. I'm excited to hear about the cases you've submitted to Dr. Sarah, and she'll work through as many as the hour allows. And we do encourage you to be collaborative in this session. If your case is being discussed, please feel free to turn on your camera and microphone so you can engage in a real-time conversation with Dr. Sarah. And as always, if questions come up along the way, please drop them into the chat. Dr. Sarah will be keeping an eye on it. She's very good at looking at that, and we'll pause throughout the session to respond. Following today's session, we will send out a brief survey. The most important question that I'd really want you to answer on that survey is, what type of clinical topics do you want to hear about this year? Specifically, things that you're finding the most challenging or would like the most help with, because we want to sort of frame the rest of the year in terms of our clinical learning, whether that's a webinar or the workshop that we do, based on what you would like to know more about. So take it away, Dr. Sarah.
Hello, everyone. You're going to deal with my 1-900 voice a little bit today, so apologies in advance for that. But yes, I am so excited to be able to dive into a live case overview today. So it's definitely going to be different than many of our previous webinars in that I am going to go through exactly what I'm thinking at different points. So this came up for a couple of different reasons. One, because you guys do fill in those surveys. They're very helpful. Saroma and I get an understanding of where people are struggling and where they need support. And one of the things that I've picked up, whether it's through my teaching, through the treatment room, or through the work that I'm doing here, is that there's this felt sense of just struggling to even know how to pinpoint what you're struggling with. And I get that. And it's really hard to articulate and it's hard to communicate. You're like, I don't know what I need help with, but I'm just lacking confidence in XYZ way. And one of the things that I have found immensely helpful in my career, and especially in the last couple of years, is just being able to deeply understand how someone's thinking and what is going through their head at different data points. And so I am really excited to do that today. As Saroma said, I will be in the chat throughout the whole thing. So if ever I'm saying anything or going through anything and you're like, I have no idea how she got there, this session is for you guys. This is not me just harping on. It's connecting the dots and helping you leave with confidence, with just this feeling of like clinical awareness of a topic. We're doing and sticking with a lot of complex cases, post-viral, potentially cases, and diving into just a deeper understanding there. So don't ever hesitate to pause me. So we're going to do 2 cases for sure, potentially 3. I'm going to go through reference ranges, and then I'm also going to talk about treatment planning. So first and foremost, always keep in mind, I did not work for Life Labs. This is not Life Labs vouching for everything I'm saying, especially with these clinical conversations. You guys are responsible for your own clinical judgment, and I am using the best of literature and my clinical practice, but I don't work for Life Labs. We've talked about this before. Just wanted to clarify. So the first case, so unfortunately, the clinician who submitted this let me know that she was very sick, as is going around, so she would not be able to make it today. But I have a really solid case overview. So the first case is a 52-year-old male. So let's dive in. So this patient has no history of previous health concerns. So felt like he felt really good. Life was good until the pandemic. And so he didn't cope well and stated he had developed depression and gained weight during the pandemic. So let's go through this. So pre-2020, this was one of the things that I had said is like, what do we need to know? What's our baseline? Generally healthy and energetic, physically active, played sports twice a week, good exercise tolerance, stamina, stable mood, no baseline anxiety or depression, digestive disorders were absent, so function was normal, whatever that means, right? Weight was stable, and felt like family relationships with wife and 2 adult children were strong. work stress was present at times, but situational and not chronic. So when we're looking through this, my immediate thoughts go to, okay, develop depression, gain weight. What changed during the pandemic? Like, what do we need to have on our list in terms of being able to start to tease these things apart? So, first and foremost, sports were eliminated during that period of time. He doesn't talk about a lot of social time other than sports, unless he played like a solitary sport. So, I'd ask more questions around that. That can affect mood. That can also affect weight, right? So, understanding both of those things is going to be an important piece of it. Stable mood, so we don't have a history here. That's good to know. And then overall, when we see the components of life that would be protective factors, strong relationships, stress, etc., they're all relatively well controlled. So that's good. So then in 2020, significant reduction in physical activity, decreased social connection. Okay, there it is. Reduced ability to see children. So I guess the strength of those relationships were challenged. No major symptoms were initially noted, just subtle lifestyle changes, less movement, altered routines, which we saw for so many people. And didn't state in here, but large amounts of alcohol consumption. That was something that happened a lot during the early part of the pandemic as well. So late 2020 into 2021, received 3 COVID vaccines through 2020, 2021, tested positive for COVID twice, reports a clear shift in health in 2021, energy noticeably reduced compared to baseline, and mood shift happened. So this is really important because if we were expecting that this situation was just due to lifestyle and the challenges that we're presenting, then we would probably expect it to be in 2020 that we would see some of the mood and weight changes happening. But we see here that it was into 2021. So this starts to raise my awareness as I'm like, okay, there's something going on here that we need to understand. So 2022 developed heart palpitations. Ooh, we're seeing this a lot in practice right now. Transition from low mood depressive symptoms to anxiety, reduced stress tolerance compared to pre-pandemic baseline, and physical resilience notably diminished. What is your immediate thought in that situation? For anyone who wants to you can again come off mute, we can chat through it, or you can put it in the chat. Immediately, those constellation of symptoms are very telling to me in terms of what my DDXs are. So what are you guys thinking in that situation? I know it takes a second for the chat to populate. So just what are your DDXs? Start throwing them out to me. There's no wrong answers here. Because through our DDXs, that's going to be how we start to decipher what labs we need to do, how we need to navigate, etc. So what are our DDXs based on heart palpitations? Went from depressive symptoms into anxiety, reduced stress tolerance, and reduced physical capacity. Cardiovascular workup needed, long COVID, post-viral thyroiditis, hyper. Yep. Anyone else? POTS. Okay. Anyone else have thoughts there? So vaccine side effects. Yep. So there's a couple there that are, well, all of those are actually really important ones. But when we're looking at the breakdown, so the development of heart palpitations, obviously we're going to want to work that up. We're going to want to understand that. But fundamentally, to me, when someone goes into from low mood to heart palpitations and anxiety, that's a systemic challenge, right? That is a overall patterning problem. That can be immune based, that can be norepinephrine, epinephrine based, but something biochemically has shifted to result. Getting someone out of depression to anxiety is actually a pretty big shift. And the heart palpitations. So I would say on my side of things, post-viral thyroiditis is the number one. So we've seen a ton of heart palpitations come in to the clinic. We've seen a lot of patients diagnosed with Graves' disease, but they never actually tested TRAb antibodies or TSII. And so they are making that diagnosis based on a low TSH and moderately high levels of T3 and T4. But then if they give them the natural treatment or like the typical treatment, which is methimazole or PTU, the patient doesn't do very well. They have to go on extremely low dosages. They are very easily pushed into hypothyroidism. And so that's oftentimes because it is autoimmune thyroid in origin. So that's a big one. The other thing we know to be true, and I have a free talk all about this if you guys are interested, is just how many clotting factors came into the mix. So we did see like just quote unquote thicker blood. We did see a lot of changes to the clotting cascades. We did see inflammatory changes. And so these are all big things that we need to have in mind. Metabolic syndrome, insulin resistance for sure. That's going to be on our DDX list. Because of the palpitations with the depression to anxiety, that's what makes me think there's an underlying energy system that is involved. So when I say energy system, cortisol is an energy system, epinephrine, norepinephrine is an energy system. When we look at thyroid, it's an energy system, meaning that you can push it too high. Your body's never going to, can everyone hear me okay? I just got a comment that yes.
I can hear you fine, Doctor.
Thank you so much, guys.
Yeah, just maybe turn up your, you need to try and figure out turning up your speaker volume if you're using headphones. Because yeah, I can hear Dr. Sarah totally fine.
Awesome. Thank you. Yeah, I always appreciate when people let me know, because if you can't, that's the worst. When you're sitting there, you got your ear to the camera. So no, I appreciate it. Okay. So when we look then at stress tolerance decreasing, that can be so many things. So that reduced stress tolerance can be mental emotional impact, can be related to blood sugar, can be related to adrenal function. We're seeing an epidemic of low morning cortisol right now. If you guys are not testing cortisol in your patients, please do. We are seeing a lot of secondary hypocortisolism. There's a technical term for that. But anyways, you know what I'm talking about, like in the 100s, early 200s. So that's a piece. Physical resilience noticeably diminished. That plays into energy production systems. Does your system have reliable energy at the right time? And then we also see that is going to play into mitochondrial function. So the energy powerhouse of the cell. So these are all the things I'm thinking when I'm going through here. Then 2023, digestive system, constipation started to come up, lots of headaches. So headaches more frequently, brain fog, joint pain, weight gain became more apparent. Notice that clothes no longer fit. Okay. Then 2024, as the world opened, so I guess expected improvement with return to life, but anxiety, brain fog, joint pain, digestive dysfunction continued. Weight 20 to 30 pounds above baseline, weight gain in the abdomen. Okay, needed a whole new wardrobe. This is one thing that coming out of the pandemic, we saw quite a bit actually. People like lived their lives in sweatpants and then they went to put their jeans on or their work clothes and they were like, oh my gosh, okay. So I'm assuming that's what that is. No clear return to prior energy, fitness, cognitive clarity. And then 2024 to present, palpitations, brain fog, headaches, constipation, joint pain. So everything really remained. Initial visit was in 2024. Primary concern was mood symptoms. Okay. And then fatigue, reduced resilience, patient not ready to invest in lab testing at this stage. Okay. And then interventions was ashwagandha, zinc, turmeric, vitamin D, increased protein, anti-inflammatory diet, support mood through social connections, routine time outdoors. Love that. And then okay, so patient preferred to defer labs, trial of low-cost therapies. Let's see how that one. Okay. Patient's response, adopted anti-inflammatory, higher protein, mild symptom improvement, mood improved, lost 5 pounds, but really still struggling with those core symptoms. Foundational interventions helpful, not sufficient. And then we got to get into other things. So post labs, so we're going to get into the labs now. Did natural desiccated thyroid, liver support, vitamin D injections. And then they're looking for my help on what to do next. So let's get into this blood work here. Okay. Any questions about the case or how I came to those conclusions before I get into blood work? Everyone's good? Okay. So let's look at this. So we've got a white blood cell count sitting at 4.7. So on the lower end, especially for men, we want to see it at least 7. So not looking awesome there. And then when we look down at where it's coming from, so we see neutrophils are very low, lymphocytes are on the low end, but the majority of the low is coming from neutrophils. I'm going to try not to cough on you guys. So when we look at this neutrophil phenomenon is something that we're actually seeing a lot like in this hot moment right now. The virus that is going around, we are seeing a lot of people with low white blood cell counts, like frankly low. We're seeing them and we have advanced women's and men's health now, and we're seeing them in the like high 2s, low 3s. So a lot of neutrophil activity. And remember, this is very important because neutrophils, how they defend the system is their job is to blow up. And so they create something called the neutrophil extracellular trap. And that blow up process means that there's a lot of damage and collateral damage that occurs in an effort to regulate the immune system. And so not only does it result in damage, but it also fundamentally results in a poorer immune response for the next virus coming around. So we have people who are having 3, 4, 5 back-to-back viruses, and they just feel like they can't get themselves picked back up because of this low white blood cell count. So definitely important to note that. Red blood cell count we generally see it closer to 5. So it's a bit low here, but oftentimes we do see that closer to kind of 5.5 in men. Hemoglobin is good though at 1.5 or 154. MCV I'd like to see it at 90. It's a 93, so not too bad. And then platelet count is a really big one. So we do have to look at platelet count here because this is something that we are seeing show up a lot in post-viral cases, is that we're seeing either very high or very low platelets, and that's due to fibrinogen. Well, and other clotting factors. We're also seeing high D-dimers. ESR is 23, so erythrocyte sedimentation rate, we would like to see that between 2 and 5 at 23, so definitely some high inflammation there. Okay. If you guys have any questions, just throw them in the chat. I'm going to keep going down my lab list here. Fibrinogen was tested and is normal, so that's good. Again, we're wanting to understand clotting factor pathways. You see iron here tested, so 25 is pretty ideal. What range of platelets do I look for? Great question. So with platelets, as a general rule, they are going to sit kind of like 250 to 300. We have a few different ways to understand platelets and normal platelet levels. So there is something called the PLR, so platelet to lymphocyte ratio. And so we want our platelet to lymphocyte ratio to be over 100 in this situation. We do see that's the case. But obviously, if lymphocytes are very low due to an autoimmune reaction or a kind of utilization or depletion pattern with white blood cells, then you're not going to see that. But generally, it is kind of in that 250 to 300 range. Good question. So as I said, iron is good here, but transferrin is on the low end. So transferrin, we do want to see right around 3, which is oftentimes when I say that in talks these days, people are like, what? It's never a 3. But transferrin is made from the liver. And because we are dealing with very hepatotropic viruses, we are very much seeing that there is an inflammatory response happening at the liver, reducing the liver production of things like transferrin, ceruloplasmin, even reducing albumin in some situations. But we don't always see liver enzymes elevated. Ferritin's very high, so this is another sign of liver inflammation here. When we're looking, there's no exact ratio. I get asked this question a lot. What is the ratio that we expect with ferritin and iron? There isn't one. We do not have a clear-cut ratio that we expect. But what we are expecting to see is if we have a quote unquote normal or healthy range of iron circulating, then we should have a healthy amount in the bloodstream. And for men, this is oftentimes in that 150 to 100 range. It is higher than in women, but 765 is high. Now, what I have seen practitioners do in the past with this is they then start to have conversations about hemochromatosis. I'm not upset at a conversation around hemochromatosis. It's just if you have an iron circulating level that's normal, and if you have, and let me see, I can't remember. Yeah. So we do have here these elevated liver enzymes, and we'll get into that in a second. So if you do have concerns about it, then you can reflex for that testing. But I always say if you can reduce liver inflammation in the course of a 6 to 8 week period, you retest by 3 months at the latest, and you see this all come down, then there's no need to push for that additional testing if there's no family history. So that's a big question I get all the time is when should I be concerned? You can be concerned whenever you want to be concerned. Is moral of the story. Obviously, these are your patients and it's your clinical judgment, but I'm often not concerned if I can make this move and retest within a 3-month period. Any questions about that? I know iron dynamics is something that Saroma and I have done talks on in the past. So if you want to go a level deeper, even we were sharing that link on my on my NCM call the other day. But there are lots of options to learn more. Okay. So then we have a glucose random. I actually don't know what time these labs were done. Let me just see if I have any data here. I don't. Okay. So glucose random is 5.8, HbA1c is 5.8. So we know HbA1c is already elevated. Not shocking given the weight gain. And then sodium potassium levels are fine. Chloride bicarb is fine. Urea is that's urea cycle for liver. So that's helpful. Urea and urate get mixed up oftentimes. Urea is looking at liver function in a big way, bit of kidney function. Urate is looking at insulin and gut bugs. HbA1c, we want to see less than 5.3 in an ideal world. So this patient was at 5.8. When they're at 6, they're technically pre-diabetic. So I like to see that level is less than 5.3. Okay, so then we see here, so this patient's creatinine is 94, which is actually pretty good so long as they have a decent amount of muscle mass. So creatinine is giving us an indicator of again, especially in men who have a large amount of muscle mass, that as an indicator, it can also give you an indication of kidney function, which we do see is a bit reduced here. We'd like to see that over 90. And that's at 75. So just asking questions, is this creatinine reflective of this patient's muscle mass, body mass, mitochondrial health? Or are they supplementing creatine and didn't tell you? It doesn't necessarily show up as much in here. I have seen it in some patients shift, but definitely not reproducibly for our creatine patients. But yes, in any situation, the kidney function has decreased. So this is an important one because the EGFR is your glomerular filtration rate. So the kidneys, we've all seen the diagram, right? Where there's this 2 systems in this filtration pathway. And so they are what we call a microvascular unit. So they are sensitive to changes in blood pressure. They are sensitive to changes in blood flow, to immune complexes. So when there's inflammation, an immune system creates these like stacked immune complexes. They look like jacks. They're very sensitive to that. They're very sensitive to microclots, and amongst many other things, diabetes, etc. So definitely a situation where we're having to ask questions about what's going on there. Seeing more and more low EGFRs, I know. So not to sound like I work for Life Labs, but we do have the Clin Risk panel. I know BC, I don't think anyone from BC is on here, but they're getting cystatin C. So we are getting the option to do more advanced kidney function testing because we are seeing a lot of these issues. So in this patient's case, we didn't know the patient's blood pressure. So that wasn't something that was on the case history. And again, unfortunately, the clinician was sick. So we need to understand that. We see that HbA1c is 5.8, but not necessarily huge issue, right? We are assuming there's some immune activity going on. And so that immune activity is something that we have to better understand. Microclots are always an option and unfortunately very hard to diagnose. We have a lot of patients coming in with microinfarcts in specific tissues, microinfarcts that are identified on ultrasound, of, again, lower legs, etc. We are also seeing that there are changes to thyroid function, to even like the brain. I have a couple of patients that have signs of microinfarcts in their brain, their ovaries. We're seeing lots of POI. So we don't really know until after the tissue has changed, unfortunately. So with our EGFR, we want it over 90. And with our creatinine, there is a bit of a gender specificity. So around 100 is good for men, like 100 to 100, and even no, I would say around 100 is where I'm looking at it. In women, we would like to see it closer to like somewhere between 70 and 180 plus being a positive thing. Good questions. Yes. So let's get into the urate now. So the question was urates associated with gut bugs. So high levels of urate in the medical literature are more associated with insulin resistance and with bacterial dysbiosis and overgrowth than they are actually associated with like high purine foods. So what we think is happening is when you're eating a lot of high purine foods, because there is that correlation, it's just not causation, in people who have an altered gut microbiome, how they metabolize that is altered. There is some conversation about there being a genetic relationship, but I can tell you in my practice, if I correct someone's insulin resistance and eradicate an overgrowth of bacteria, then their urate drops precipitously. So to me, it's a really cheap soft marker of what is going on with the gut microbiome and insulin signaling. So very helpful in that way. We want to see urate, like ideal world, less than 350 in men, 250 in women. Okay. So we see here, to go back, we did look at their changes with transferrin, and we see albumin is intact. So that's actually a really positive thing. Total protein is intact. So that's a positive thing. So we're not necessarily looking and saying, are we spilling something through the urine and the kidneys in that way? Then we see bilirubin is a bit higher than I would like to see it. The total, I would like to see it less than 10. It's at 13, so not the end of the world. And how we look and say, okay, is this a problem? Is we go back to this patient's CBC. So the patient's red blood cell count is a bit on the low end. So what you would do in subsequent testing is when you are monitoring, you would always, this is part of why the new liver digestion panel, well, this is why I've decided the liver digestion panel has a CBC, even though it's actually because of the platelets so that they can, so that they can calculate FIB4. But when we look at the red blood cell count, if you see bilirubin go up a lot and red blood cells go down a lot, then that's a sign of hemolysis. So that happens a lot in our post-viral patients. So we're always needing to understand that. Okay. And then ALP is okay, generally closer to 100, but it's okay. GGT is okay, but our ALT and AST are very high. So we want to see those less than 25, ideally, definitely less than 30 in men. But we don't see lactate dehydrogenase very high, indicating a lot of tissue damage. So that's a good thing. Do you ever look at total bilirubin low as in altered oxidative and ROS status? So bilirubin has a relationship to as an antioxidant and in scavenging, but in of itself, I haven't seen it depleted by high levels of oxidative stress, if that makes sense. So it's very involved in that process. I just haven't necessarily seen that marker gets driven really low or gets used up, if that makes sense. Okay. Oh, here's our fasting. So the patient was fasting. So after 17 hours, the patient's HbA or average glucose or random glucose was 5.8. So yeah, that's too high. Triglycerides are too high, should be less than 0.7. Cholesterol, total cholesterol is okay. It's just the HDL is non-existent, which happens in the case of, to speak to, a lot of oxidative damage or insulin resistance. So we'll want to see that improve. Fasting insulin's very high. So we now have a fasting insulin of 189 and a fasting glucose of 5.8. So this patient's very insulin resistant for sure. I would love a 2-hour insulin glucose challenge test, but didn't get that. All good. We want to see insulin less than 50 fasting. It can even be lower in men. Like men do quite well when it's in the 30s. Okay, TSH high. So it's likely that this patient had post-viral hyperthyroidism and now is dealing with post-viral hypothyroidism. T4, we want to see that closer to 16, although that's a pipe dream these days. And T3, we want to see closer to 4.5. So, but they had given them NDT afterwards. CRP is 0.8, and then vitamin D is low. Okay. When would you think about a 2-hour, I think you mean insulin glucose challenge test. So the OGTT is oral glucose tolerance test. It's just glucose. They test glucose at 4 points. The insulin glucose challenge test is 4 points in Ontario, and it includes insulin and glucose. There's also a different glucose load. So I almost always do the postprandial test. Here's why. So for many of our patients, if their HbA1c is like higher, like 6.5 and higher, they're insulin resistant. We don't need, honestly, to think too much about it. But when you have your patient and things are getting better controlled, or you have a patient whose HbA1c is normal, quote unquote, you have to do a 2-hour test. The majority of our patients are spending their life fed, not fasted. So if we are only testing fasting and we're assuming we understand physiology, we are wrong. Like there is more and more literature coming out now that's showing that our home IRs, et cetera, are helpful in terms of understanding medication thresholds, but not necessarily for us because we're working in the world of diet and optimization. So I very, very firmly stick there. Why is the Life Labs normal range for fasting insulin so high? Because the world is insulin resistant. They are not. Life Labs never pretends these are healthy ranges, right? They're diagnostic ranges, and so you're always going to see really wild ranges just because, again, they're what's coming into the lab, not necessarily what health looks like. So yeah. Great question. Okay, what does it mean when ESR is high but CRP looks good? Awesome question. One sec, I'm going to cough. Sorry about this, guys. So when we look at ESR is a long-term marker of how much inflammation is on a red blood cell. Okay, the test that I would like to see, which we do not have yet, if you can find this research study, I would love to see it. I have not been able to find it myself, is how ESR changes with HbA1c. Because in theory, the more of anything that's stuck on a red blood cell, the faster they're going to fall. So if your average glucose is high and there's inflammation on your red blood cells, will that fall faster? Anyways, that's the total aside. So there's a couple different things I think about in this patient situation where CRP is normal. One, they have very high ferritin and they have high liver enzymes. CRP should be coming from the liver. It's an acute phase reactant that's made from the liver. So my immediate instantaneous question is this patient's liver not making enough in general? And will we see the CRP go up over time? So I had a patient, he was 19, and on the radiology report, the doctor or the radiologist had said, this is the worst case of fatty liver I've ever seen. Like there was a 1 by 1 centimeter focal sparing area of fat. Everything else was fat. And as I treated the patient, so his CRP got higher and higher and higher and higher and higher. It wasn't because he was getting more inflamed. It was because his liver was actually able to produce what it was supposed to produce. So I don't know that that's the case in this situation, but CRP is a long-term marker, or sorry, ESR is a long-term marker. CRP is a very short-term marker. It goes up and down. It responds to acute very well. ESR is responding to long-term changes and what makes red blood cells heavy. So hopefully that can give you some clarity. So I think that was it. Yeah. Okay. So with this practitioner, she gave natural desiccated thyroid, which I agree with. In this situation, I would have done at least 60, depending on the patient's weight, which I don't know. Sometimes maybe even 75 or 90 milligrams. Vitamin D injections, agree with wholeheartedly. Then I think they did ashwagandha, turmeric, and zinc. Wouldn't necessarily have been my way to go, but that's why they're asking this question. So where do we go from here? First and foremost, when we look at the labs, they did an overall pretty good job. I don't necessarily in this moment need to update and do a 2-hour insulin glucose challenge test. We know the insulin resistance is there. Like we know it's not good. So we don't need to reflex into that. I do think it would be helpful to do a clin risk in this patient just to understand one of our big factors, which is kidney function. But we could redo that at the 6-week mark when we redo thyroid labs. So we could do clin risk thyroid labs at that point. You can also honestly make pretty significant changes in urate at 6 weeks. So if you wanted to test that, because one of the things that we're going to be doing is antimicrobials. So you absolutely could do that if you wanted to. For when we're looking at liver function testing, we are really looking at that 3-month mark. Cholesterol 3-month mark is often my retest point. Same with ferritin. It will move pretty quickly, but not in a stable way until 3 months or so. And then of course, HbA1c is 3 months. So we're going to send this patient for updated thyroid labs. I do my labs at trough. So I do TSH, T3, T4, and then I would add on anti-TPO, anti-TG in this patient's case. And I would do that 6 weeks after meds. So the patient would take their medications in the morning, not take their medications for 24 hours, and then go to the lab again. So that would be my lab outline. In terms of what else we're going to do for this person. So I think, let me just go back and see. So they gave liver support formula. I would be giving liver gallbladder complex by Designs for Health. That's one of my fave ones. We need to address this constipation. So that's going to be a big piece because anything that leaves the body has to leave through your poo. So hopefully the thyroid supports that. But then I would also be doing magnesium citrate, probably 300 to 600 milligrams at night, plus added fiber to help with some of that LDL. So that could be PHGG, 5 to 10 grams a day. That could be silly. Like lots of different ways to do it. And then food insulin demand diet is going to be a big thing. Okay, so I've got, what do I have on here? So I've got liver gallbladder support, vitamin D injections or liver gallbladder formula, vitamin D injections, NDT, magnesium citrate. I would do Candibactin BR as my antimicrobial. Why? Because it's got berberine. So I would do 2 caps twice a day. It's got berberine. It's going to help with the lipid panel. It's going to help with the insulin resistance. It's going to help with urate. It also has Coptis, which is just general workhorse. It has some antiviral properties, has licorice and Scutellaria bicolensis, which are antiviral. So I would do that. When antibodies come back positive or at any point, you're gonna wanna do some black cumin seed in here, probably some selenium, and then the mood piece. So this patient has experienced anxiety and depression. Um, we didn't test testosterone. I would actually probably test testosterone because we do know 1 second. We do know that the viruses can hit the mitochondria, but it can also hit the testes, and we can see a pretty significant decrease in testosterone. So I'd be testing testosterone here too. And like honestly, I love a good saffron. So to do 28 milligrams of saffron, or there's a few different ones. There's like a saffron matrix, which I think used to be testo matrix, but to do something that can help with androgens potentially and also help with the mood would be high on my list. And then I would follow that with an understanding of mitochondrial support. I wouldn't do mitochondrial support right out the gate because you've just got a lot of work to do. We need to get gut microbiome down. We need to stabilize insulin signaling. We need to get inflammation down. But then I would probably, so that would be plan one, see them at 6 to 8 weeks with their updated labs. And then I would probably switch the candibactin to a black cumin seed, obviously, so long as all's going well. I would do potentially even like a Seroplus or an inflammatone for some of the joint inflammation if he still couldn't work out. So I would be looking at what I can do there and then be giving probably mitochondrial formula by BioClinic. That would either be visit 2 or visit 3. So, a couple of things, and obviously you guys can ask questions, and then I'm going to move on to the next case. But a few different things that we really need to think about here. This is likely caused by a combination of inflammation, gut bugs, and fat in terms of the elevated liver enzymes. So you don't need to do liver gallbladder complex for 6 months. You can understand that lowering insulin with food insulin demand principles, by using berberine, by using antimicrobials, all of those things are going to help. So when you're dealing with supplement burden, always keep in mind you can pull supplements in and out. And then also keep in mind when I'm talking to any patient, I don't care what patient it is, I generally have the next 6 months mapped out in my brain. So when I'm working on their intake, I am documenting, okay, plan 1, plan 2, plan 3. When they come back in, if their symptoms change, then I will change my plan. But I always find it such a waste of time to only think about one visit. Like I'm forecasting out what it's going to take to get this person better, not necessarily what it's going to take to get this person to the next visit. And so it saves me a lot of time because I'll write down my whole plan and then I will modify it and change it as the patient comes in, of course. But at least I'm not starting from scratch every visit. So just a little clinical pearl there. How long does it take to reduce ESR? So technically, according to the research, ESR can fly up and down within like a couple week period of time. But it is a situation where I oftentimes will give it at least a month to level out, if not 6 weeks. If CRP is constantly high over serial lab markers, does it mean they're having repeated acute inflammatory events? No. Great question, but no. So even just having fat in the liver or having necrotic tissue within the fat pads, especially like visceral fat, can cause a high CRP. It does not have to be like acute triggers. It can be chronic. Great question. Any other questions? Was this helpful? I just like I'll get feedback halfway through. Was it helpful to like see how I'm thinking through cases? Okay, awesome. Awesome. I love that. Cuz I like don't do this just to sit and talk to myself. If that was the case, I'd talk to my team all day. Repeat antimicrobials. So the main ones, candibactin BR and black cumin seed, I think would be the first two that I would think about using. Okay, cool. So lab tests at 6 weeks, TSH, T3, T4, anti-TPO, anti-TG for sure. Urate, you could do at that point. I think, honestly, those would be the big ones I would do, and then 3 months, you'd be doing a big overhaul. ESR, you could totally do at that point too. You could even throw on a CRP. Like, honestly, these are $5 tests, so I always say if it's gonna increase my ability to do my job, patients are happy to pay it. Okay, awesome. Great questions. Okay, so case 2, I believe Dr. Turk is here. Yes, I can't see who's here, so I don't actually know, but, if you are
Yes, Dr. Turk is here. Dr. Turk, this is your case. You can turn on your mic and camera.
You're here, perfect. Okay, so while she's getting set up on the tech end, patient came in with diagnosed with fibromyalgia, very complex story. I agree with that wholeheartedly. Ooh, your audio is thanks. Sorry. Yeah, audio is not working there.
Dr. Turk, sorry, just give me a second. I muted you until you fixed your audio because it was really
Yeah, your
loud.
audio is coming through as static, unfortunately. So it's probably connected to the wrong mic.
How's this?
There
Okay,
we
there.
go.
Perfect.
Okay, I'm just finishing with the patient that's here. If you want to present what you've got, and then I've got you on the volume on, and then I'll come back and jump in just a second and answer
Perfect.
anything you need on top of this crazy complex case.
Yeah, no, all good.
Perfect.
All good.
I'm gonna mute you now.
Yeah.
Okay,
The
there we
joys
go.
of being able to bring people off mute. Okay.
Okay.
So, possible POTS, lupus. She has IHH, which is intracranial hypertension. Yes. I'll just get the exact name of it. IHH. It's idiopathic intracranial hypertension. Oh, so close. So MRI showed a pinch in the CSF pathway. So idiopathic can be a lot of different things. I actually see it a lot in patients who come in with severe insulin resistance and obesity. So that's one of my top DDXs. Obviously, there's a lot of DDXs there, but she's in pain more often than not, trouble with concentration, ADHD type symptoms. That's honestly coming up so much these days. Instantly, I'm like insulin resistance and histamine pathway. We've got POTS, which is a histamine pathway. We've got lupus, which is autoimmune. Fibro, we used to say it's a diagnosis of exclusion. It's not now. So in this situation, fibro is mitochondrial. Oftentimes, there's a viral component to it, and there's also an issue with what we call P5P, or the pentose 5 phosphate pathway. I can get that out today. I can talk. So we're looking at energy, metabolism, ability for mitochondrial to work, keep blood pressure stable, histamine issues. So then we're going to keep going down. Sensitivity to medications, Kate, that's histamine issues. That is glutathione pathways. That is nervous system. Those patients, this is a clinical pro. I have this on my intake form and I never ask questions about it and patients get mad because they're like, why did you put it on your form and not talk about it? But patients who respond to everything, perfumes cause headaches, scents cause issues, this cause, like, they're just totally like, their pathways of elimination are messed. So that's liver, that's histamine, that's even just like overstimulation from a nervous system perspective. But we're seeing that so much right now. Patients are like bloodhounds. They walk in and they're like, does someone have perfume? You're like, okay, whoa, whoa, whoa. So it's that hypersensitivity piece is a big one. At age 12 was diagnosed with POTS, some form of dysautonomia. Okay. So this patient's 19, I think, 18, 19, something like that. Yeah. Okay. So when we're looking, that's 7 years ago. So that's pre-COVID. But this is where we can look at like staph and strep coming up. EBV is very endemic in that issue. Chronic back pain since 8. Like all of this is given endo too. I don't want to say given. Clearly, I watched too much Love Island. I'm like, it's given endo. But this like starting to go through puberty, starting to get back pain, then getting this kind of age 12 POTS, dysautonomia, migraines is a huge endo symptom. Really, all we need is digestive issues and pelvic pain to put a little bow on that. Vision impairments ruled out because migraines, there's a very strong histamine estrogen connection with migraines for sure. Oh, you're still staticky, unfortunately. I can't hear you at all. It's just static. Sorry. Yeah, maybe try different headphones, or you can also call in. Saroma, can you send the instructions on how to call in too? Okay.
Yeah.
Variable pulses with a difference of 40 BPM. Okay. Cycled more on the tachycardia than bradycardia. Chronic fatigue, 2 out of 10 goes with the fibro and the energy production. Okay. What else do we got here? Diagnostics. No, darn. It's just static. So weird. So sorry. You can type in the chat too. That might help. Manage mic. I'm not sure if we can control it. Okay. MRI. When MRI since she was 8, X-rays. Brain MRI showed a pinch in her CSF pathway. Recent. Negative RA. Negative celiac. Iron deficiency in the past. Iron infusion didn't change symptoms. 14-year-old, heavy periods. Oh man. Does she have short cycles too? Like less than 24 days? That's like, to me, diagnostic of endo. No, it's not. I can see your head shaking. Okay. Doesn't eat much. Been concentrating on lots of red meat. Mild changes with IVs and NAD. I believe you said difficulty getting her to take supplements too. So hence the IVs. Yeah. Okay. And then looking here, so we've got, so on labs, we have an ESR of 2, so nothing too crazy there. White blood cells of 4.8, so a bit on the low side. Red blood cells are fine. Hemoglobin, fine, honestly. MCV 88, so a bit small. RDW on the low end, so not making a lot of new red blood cells, but also realistically, her red blood cell count's fine, so it might just be she's not breaking them down as much. Platelet count is okay. ALT 14, CRP at high at 8.9. Rheumatoid factor negative. Not very compliant with supplements. We've got an IgA of 0.6, so that's okay. Bit on the low end there. IgG's normal. IgM. Do we have an IgE? Vitamin D is 165. B12 a bit on the low end, of course. TSH, ferritin 99. TSH is okay. Okay. So let's, don't have the labs open. Okay. So yeah, we'll let you focus on the call-in part. Sorry, I'm like, can I ask you 10 questions at once? Like, why can we not do this? No, I'm joking. So IgA, ideally you're looking at like 1.5. So it is on the low end. The thing with IgA, it's just, you have to ask questions about, is it being used to defend against something in the system, or is it not being made? Because IgA is our first pass for our immune responses. The IgG is one of the bigger ones. We are seeing selective immunodeficiencies right now. And so that's where IgG comes back quite low, and those patients are actually having to get intravenous immunoglobulins. So while we're going through and getting an understanding of like any other questions, immediately in these situations, this is where more lab work doesn't always give us the answer. So I'm always looking and saying, okay, what can we do at the gate? Most of the time, and oftentimes, these patients are not super compliant because they don't know the difference. So almost always what I prioritize is something that's going to move the needle. So just looking at this in this patient situation, immediately here's where my mind goes into like kind of 3 steps. Step 1 is electrolytes, mitochondria. Why? Because electrolytes is going to give you the blood pressure she needs. It's going to stabilize some of the tachycardia. To my knowledge, and this is what I would be looking up. I'm just coming into this blank as I would be going into a visit with you guys. So I would look up the impact of electrolytes on CSF. I do not believe it has a significant impact. I do think it's a distinct system, but I would just double check if there's any contraindications with high doses of electrolytes. Like I use the element ones because I think they taste the best, the LMNT, but I will do 2 to 3 elements a day for these patients just to try to get their blood volume up. You can also do the same thing with saline, right? But they have to come in really frequently. So you have to come in for an IV, but just like bags of saline and just see, do you feel better within the 24 hours afterwards? Now, when you say feel better, you just mean slightly less dysautonomic, slightly less tachycardia. So you'd be measuring that patient's, this is where these things are super handy. You would be measuring that patient's heart rate for the 24 hours after and saying, like, is this a situation where we can get consistency and get an improvement in some of those dysautonomic symptoms? So element, like I said, up to 3 per day, which is a large dosage of sodium, but sometimes can stabilize them. I would be doing Claritin, like OTC antihistamine Claritin. Because if you get any symptom relief with that, then you can move to your quercetins and your luteolins and your mast cell stabilizers. But to get a bit of a win, I do find Claritin or Zantac, the H2 blocker, can be helpful. And then, like I said, moving more towards your natural antihistamines. And then I would be doing mitochondrial formula, again, by BioClinic. There's a theme here. I love that one. I'm not actually joking. I love that one. And then with ribose in it and potentially creatine. So the whole goal with that is, okay, we'll have that conversation here in a second. But the whole goal with that is to say we need to get mitochondria a little bit rehabilitated, reduce pain, reduce histamine responses, reduce migraines, like stabilize. Then from there, you can look at the other work you need to do. But sometimes with these patients, it takes 3 months to stabilize them. It takes 3 months before we can do anything to their gut microbiome, anything to their virome, anything to their liver at all. And don't hesitate to take that time should you need to take that time. So if someone won't take mitochondrial formula or something like that, you can offer them the alternative, which is they can take 300 milligrams of CoQ10 and 300 milligrams of carnitine. If someone says, I won't take a powder, I won't take a potion, I won't take any of your supplements, I tell them they don't want to get better. Like, I will just very frankly be like, that is totally fine. My medicine requires you to do work. So if you don't want to do that, and this is like without any judgment, but there are many times in many people's lives, honestly, we all need to self-reflect on this as doctors. We do it too, where the disease serves you more than the illness. You're getting attention, you're getting out of school, you're getting and you see it in kids, right? But it shows up at all different stages, and it's not a judgment. And it doesn't mean it's in her head, but it does mean that the work takes effort. So like my 3, almost 4-year-old, when he coughs, she's like, oh, we're sick. Oh, we're sick. We're sick. We have to stay home and watch TV. And I'm like, we don't watch TV when you stay home. You're not at Nana's house. But it's almost like reestablishing what health can provide them other than just the disease. So if I have a patient who fundamentally is like, I will not do the element, I won't do mitochondrial support, I won't do the antihistamines, then I just say, unfortunately, in this season you're in right now, I can't help you. And that's okay. I'm here whenever you're ready to take action on these things, and I'm here to support you. But like, I'm very fortunate. I have a very busy practice. I do not have time to provide like therapy and identity and coaching support when that's what someone needs. And it's also not fair for them to pay the prices that I charge for that. So I'm like, we're going to get you in with a therapist. When you're ready, come back. No judgment, no shame, nothing. I'm here for you. But if you won't do step 1, I won't do step 3. And I think like you're already doing IVs, you're already doing some of these things. The next step just fundamentally requires that she takes ownership in this as well. Yeah. You can type in the comments if you have any thoughts or anything. And does anyone have questions about how I got to mitochondria, histamine, and electrolytes? Yes, you have questions? That is my favorite answer. Yes, we have questions. I think there's probably a bit of an exhaustion being discarded because she's been failed by everyone. Oh, I love this. Oh, you're not on my clinical rounds calls. Here's what I always say. If it is someone's choice to repeat the same action, they are going to get the same result. And our job is only to bring awareness to that. Be like, hey, because I've done this. I've had this conversation with patients many times, and I'll look at them and I'll be like, I want to have a conversation today, not from a place of a trigger, not to bring up anything from the past because I'm not your past doctors. But you have told me that you have felt unheard and unsupported and discarded by previous medical doctors. And in this moment, you are refusing to do anything that I tell you to. So I am not discarding you. I am not in any way, shape, or form saying I can't help you. I can help you. You are not helping yourself. And so if you have an idea of how to get to a place where you're ready to help yourself, I'm here for it. I'm 100% supportive of that. But I have a plan right now that I think works. And I deeply understand the fear that it doesn't. I deeply understand. Sometimes it is easier to not try at all than to try and fail. And I get that. And I get how hard that is. And in this moment, I'm asking that you trust me, that if you try this and it doesn't work, I have another plan. I am not going to tell you you're not fixable. And that little reframe for people, oftentimes, if that's what's going on, they will immediately burst into full body sobbing tears. And then you've like hit the thing. And if they don't, then they actually don't want to be better. Okay. So, okay. Revisit with this explanation, 100% agree. Our job in the world of AI, and I know I'm going a little bit late, so if anyone has to leave, like, feel free. But in the world of AI, our job is to provide clarity, to connect dots that a patient can't connect themselves, and to coach them through their own. That is our job. And no one's immune to that. Like, I work with high performers and other doctors. And I swear to God, half of you guys are worse than the patients that I used to see to begin with. Because you think you see your own stuff and you don't. But that is our job. Like I get multiple patients every single week, and about 10% of what ChatGPT tells them is actually accurate, and I like it. 25% is like decent but misinformed, and the rest of it is crap. And we expect that those numbers will double every 6 months. That means 20% and 50%. So we're about a year away from patients actually being able to put that in and get the information they need. And that doesn't worry me at all. It actually, to be completely honest, ChatGPT makes me a lot of money right now because people immediately go into like, I need a person to help me through this. So it's just keep in mind, like these coaching skills and these types of things is what people are paying us for. It's our brain for sure, but it's also that like holding them in that space and being there for them. That's so important. How much IV saline do I use? I don't do it personally. I refer out, so I can't speak to that. What do you do for bringing histamine down? So when we look at histamine, one sec. Speaking of histamine, I talk about histamine and then I get a histamine tickle. By the way, that's what that is. If you hear that in patients, that is a histamine tickle as a reference. Post-viral histamine response. It sucks. We deal. But so you need to, I think about histamine in buckets, and Saroma, tell me if I need to end anytime soon. But I just.
Oh no,
We're good?
we're good. We're, as long as you're available, we're gonna keep recording and
Okay.
just finish our conversation. So I'm really happy that you're finishing it. No problem.
Okay, perfect. Okay, so when we look at histamine, we have to look at it in different buckets. When we look at histamine made in our gut, okay, so these are made by bacteria in our gut. These are things that are responsive to enzymes like DAO, etc. Okay, so and to a certain degree, responsive to our natural antihistamines, quercetin, luteolin. Those are the big ones. And then there's a ton of our herbs: black cumin seeds, antihistamine; resveratrol's antihistamine. So many different things are antihistamine. So there's the response that's actually from the bugs. Okay, that's one type of histamine. Then when we look, there's systemic histamine. So this is response from mast cells unloading into the system. And that is from our liver, so Kupffer cells. The relationship between mast cells and Kupffer cells is really strong. So any liver inflammation can kick that off. That is a response to, again, like the typical things we think of with mast cells: hormonal fluctuations, heat, too hot, too cold, mast cell response. That's stress. So CRH, cortisol releasing hormone, triggers mast cells. So that comes up. Plus, then we also have allergens, which are inhaled, which would be systemic. Or if they're through our gut, then that would be a gut histamine response. Then we have to look at and break down what is happening with HNMT and how we get rid of histamine. So you can make a normal amount of histamine and have normal mast cell function and then not break down histamine. So this is where methylation comes in. This is where B vitamins as cofactors come in, etc. And then kind of adjacent to all of that, we have the viral histamine responses. So that Th17, which is an autoimmune reaction that involves mast cells and histamine. So everyone says like, what's your favorite antihistamine? I'm like, reducing stress and antimicrobials like fundamentally are probably my favorite ones, because if you look at the biggest causes of histamine responses, it's virals, so antivirals, bugs, and the stress response. Then from there, you can work in stabilizing with quercetins and like those different components. But it always starts with like, what type of histamine am I dealing with here? So with this patient, onset at 12, I would DDX endo. Like, I think this is an endo case. So at that point, you're like, okay, there's a probably a chronic viral component to what's going on because of the CFS and the fibro and like all of that mitochondrial stuff. There's acute viral component going on. So we need to give antivirals somewhere down the line here. But she needs to be able to tolerate it and stabilize first. Because if you give an antiviral or an antimicrobial to this patient, she won't get out of bed for 3 weeks. Like, you gotta be careful. So with that, that's why we do antihistamine. That's why we do gentle support. That's why we do mitochondrial support, those types of things first. When that patient's BP, dysautonomic symptoms are more stable and we get her up to like a 4 out of 10 with less pain, boom. Okay, then we get into antivirals, antimicrobials, what we need to do. Yes, I mean endometriosis. Exactly. Exactly. So I started my practice in fibro and CFS, which is part of why I chose this case because I'm like, these cases are so poorly managed. And so, like, to be honest, can be such a light switch opportunity for patients if you nail the right pathway. And oftentimes it does take that mitochondrial support, the histamine support to get that unlock. But the reason why I've become quote unquote good at treating endo is because the mass majority of the patients that I saw who had fibro had endo. They just wasn't diagnosed, or they were told it wasn't the cause of their symptoms. So, and then of course, many of you know I have endometriosis, so had to figure that one out. But within that, it's like that understanding of how overlapping those systems are can really set the framework for how you're going to manage these patients. Because is she on birth control or an IUD or anything? Do you know? No. Because honestly, sometimes, and it sounds like very non-naturopathic, but I'm a pretty no, I'm pretty naturopathic. I lie. I am whatever the patient needs whenever they need it. And in these cases, sometimes I will put them on birth control just to see if I can stabilize their symptoms. I'm like, can you go on this for 3 to 6 months? And sometimes that's Vizam, like the endo treatment. But I'm like, I just want to know if I can get this under control. And sometimes you'll find pot symptoms go away, pain substantially improves, migraines are gone. Okay, cool. Now I have my next target. It has to be the relationship between hormones and the immune system. So when someone is 2 out of 10, you just have to give them a foundation. The foundation is broken. We need to give them a new foundation. So, yeah. Anyone have questions on that? In what cases would it be too soon for mitochondrial support? So, I was talking to Dr. Anderson, and he says that he has Paul Anderson, is who I'm talking about. He says he has patients that he puts mitochondrial formula in and they can't tolerate it. It's like you just overstimulated the system. I can't say I deal with patients that are that decompensated that I worry all that much. Like my patients are not bed bound for the most part, like they are outpatient services. And so I rarely am worried about putting mitochondrial support in, but with the acknowledgement that he made a good point. If the mitochondria are so broken that you're just like trying to start an engine that's not working, then you could make that patient symptomatic. Is it just me? Oh, is my mic bad? No? You guys are okay? Okay, awesome. Thanks, guys. Okay. Support for the kidneys. So it's a great question. When we look at kidney support, the herbs you listed there, burdock, uva ursi, dandelion, um, zea mays, like these different ones can be helpful. But fundamentally to me, it's two things. One, the most energy dense units in our body, kidneys, heart, eyes, ovaries, right? Like these things all require a ton of mitochondrial support. So when I'm treating kidneys, I always look at antioxidant status. Glutathione can be very helpful. When I'm looking at, now you have to be careful with glutathione. I'm just going to qualify that. If you have a patient with chronic viruses, glutathione can pull things out of cells. So it can cause a little bit of a flare, but mitochondrial support, glutathione, and then understanding what those immune complexes are. And if you need to break up those immune complexes with proteolytic enzymes, anti-inflammatories, that's always my first pass on kidney dysfunction outside of does this patient have hypertension, right? Any other questions? And then I am going to have to wrap up before my next meeting. Was this helpful? Like, is this something that you guys want more of? Okay, would like to know more on when to use OGTT versus insulin glucose. Yeah, we have lots of resources on that too, so Saroma can help there. Very helpful, super helpful. Oh, great question. Eosinophils are only one source of histamine response. So oftentimes eosinophils will not be high. Very helpful. Okay, awesome.
Amazing. Thank you so much, Dr. Sarah. I'm really hoping that everyone enjoyed this format. We basically just want to know, do you want to have more like this? And then more importantly, we want to know what, I mean, we brought up, there were a lot of conversations about very specific clinical topics here, but we'd like to really know how to frame our next webinar. We do have some months in mind, especially with Dr. Sarah, and we haven't yet landed on a clinical topic. So in that survey, or just if you want to just shoot either Sarah Brody Brown, my Ontario colleague, or myself an email with what you'd like to hear about, please let us know, because we're going to actually frame our next talk based on your feedback specifically, and whether or not you'd like to do another live call like this, if this is something that's helpful to you. So please let us know. Until then, if you are in Ontario and planning on attending the Exceptional ND Conference, my colleague and I, Sarah Brody Brown, will be there this Friday, actually. So we'll see you there. And we'll be on our email, and we'll sending you a follow-up email as well with the recording for this slide. And I can also include the link to instructions on how to access the ClinRisk test that Dr. Sarah mentioned, as well as anything else that she messaged me that I should share with you all. Thank you very much, everyone. Thank you. Bye.
Thanks, everyone. Share your feedback.
Yes, please do.
Bye.